Anishinaabeg, which includes the Ottawa, Ojibwe, and Potawatomi nations, collectively known as the Three Fires Confederacy, the Haudenosaunee and the Wendat nations, and the presence of other First Nations, Métis, and Inuit residing in the Simcoe-Muskoka territory. Most of us have come here as settlers, immigrants, or newcomers in this generation or generations past. We are all treaty people. As such, we commit to collaborating based on the foundational assumption that Indigenous peoples have the power, strength, and competency to develop culturally specific strategies for their communities. We are dedicated to honoring Indigenous self-determination, history, and culture, and are committed to moving forward in the spirit of reconciliation and respect with all First Nations, Métis, and Inuit people. Today's session is being recorded and will be accessible on the SGS website. If you are watching the recording, welcome, and a reminder that if you would like to join live, practice shorts are offered the second Friday of the month at 8:30 a.m. It gives me great pleasure to introduce today's presenters, Sandra Zakos and Beverly Ann Oliver. Sandra Zakos graduated in 2009 from the Leslie Dan Faculty of Pharmacy. She worked at Toronto General Hospital for 10 years in thoracic surgery and respirology, and then general internal medicine. She is a certified respiratory educator, a board-certified geriatric pharmacist, an adjunct professor at the Leslie Dan Faculty of Pharmacy, and a preceptor to pharmacy students and residents. She is now a clinical pharmacist with Jerry MedRisk and the North Simcoe Muskoka Specialized Geriatric Services. Beverly Ann graduated from Queen's University with an honors and bachelor's of science and went on to pursue PharmD from the Leslie Dan Faculty of Pharmacy at the University of Toronto. She is currently practicing as a pharmacist with Jerry MedRisk and the North Simcoe Muskoka Specialized Geriatric Services, with both roles focused on the care of older adults. We would like to welcome Sandra and Beverly Ann, and I will now hand it over to you.
Awesome. Thanks so much for the introductions, Brittany, and thanks to everyone for joining us today. Today we're going to talk about these learning objectives. So our hope is to describe the prevalence and risk factors for falls in older adults. We're going to identify some common medications associated with falls in that older adult population, and we're going to discuss an approach for reducing medication-related falls. So let's start with a case. Grace is a 78-year-old female who's had 3 falls in the last month with some dizziness in the same time frame. She had orthostatic vitals checked and did not show a positive drop, so there's no orthostatic hypotension clouding the picture. And when gathering more information, you learn she has high blood pressure and a previous heart attack, as well as insomnia, osteoarthritis, and some nausea. The medication she takes include metoprolol, lisinopril, ASA, a statin for her heart disease, amitriptyline for sleep, Tylenol 3 regularly that she started recently, and Gravol or dimenhydrinate for occasional nausea. We'll revisit Grace, but we're going to put a poll up on the screen, and I hope you're looking at her list and seeing some red flags come up. Before we move on, I want to ask you what medications are concerning to you, so you can select any that apply. We'll give it just a couple minutes for people to get their brains engaged 1 minute in. And, I know it's not nice to start out with a poll, but it doesn't hurt to start your brain thinking about medications, because I know that's not where everyone generally sits on this call. I think Brittany, whoever's managing the polls, let us know. You're welcome to end it whenever. It seems like a decent number have voted. Awesome. So I'm hoping I will see results. Perfect. So I don't know if everyone can see the results, but it is across the board. There's pretty high numbers. So the most common, 70% of you said dimenhydrinate or Gravol. 62% said Tylenol 3s were concerning. 48 and 38% respectively for amitriptyline and metoprolol, and then lower for the other cardiac medications. So I think we're all on the right track in terms of having those red flags, which is such an interesting thing to take away because, you know, a lot of people on this call aren't pharmacists, but already you have in your brain some red flags of medications you may want to think about when we're talking about falls as one example. So we'll come back to Grace. And for now, we'll just chat about some of the other things we promised to talk about. So why are falls a concern? So we see in Canada, about 1 in every 3 older adults will fall at least once a year, with falls costing the Canadian healthcare system about $2 billion per year. Furthermore, falls are the leading cause of injury-related deaths and hospitalizations among all Canadians. So that's not specific to older adults. And most falls resulting in an ER visit happen at home or in a long-term care setting. So close to home, not like when people are out and about or doing other things. And those are pretty big numbers that apply to everyday risks then, and really highlight why we want to avoid falls as much as possible. There are a lot of ways to think about the causes of falls, but the one I found the easiest was to think of external versus internal causes. So your external causes are environmental factors like uneven ground, slippery floors, clutter in the home, or even poor lighting, and can include a lot of other things as well. These factors are common and lead to things like tripping on a rug or slipping, getting into or out of a shower, as we have heard about or seen often in our older adult populations. Internal factors are things happening inside your body. So these can include poor balance or weakness, that can be from a lot of different factors, not any one specific. Vision problems can also cause falls. So getting our older adults' eyes checked or making sure their eyes are being checked and prescriptions updated is important. And lots of health conditions can cause falls. So anything from pain to previous stroke or Parkinson's disease even, and a bunch of others. That's just a bit of an example. And finally, medications can cause falls. And that's where we're going to focus on today. So how do medications increase falls? Well, it depends on the medication. And this is kind of the 3 broad classes. There's other ways, but these are the ones that we see most commonly. So some medications make you sleepy or sedated. So you may not realize, or a patient, if they get up, may not realize that there's a hazard in their way if they're walking around while taking that medication, which can lead to a fall. Some medications can make you dizzy, which can affect your balance. And some medications can affect blood pressure. Many are even supposed to affect blood pressure. As we think about the last couple of screens ago, you know, metoprolol and lisinopril are often used for blood pressure. But when we change a patient's blood pressure, that can also increase their falls, particularly when they're changing position. So, you know, sitting to standing, or at any point they might feel dizzy. So there's a couple general ways medications increase falls before we get to the specifics. Polypharmacy is just a fancy word that means taking more than 5 medications. And taking more than 5 medications can increase the risk of drug interactions or additive side effects. So if 2 of them cause sedation, people are going to be even more sedated than on 1. We'll discuss specific drugs that can cause falls, but it is interesting that just taking more than 5 medications is also linked to an increased risk of falls and injury and hospitalization related to those falls, regardless of the specific drug the patient is using. Another general factor to consider is whether a person's medications affect vision, cognition, or motor skills, as any medications with these side effects can also increase their risk of falls. So what medications can cause falls? Let's get into some specifics of medications that can either cause falls or increase the risk of falls. So the ones I tend to think of first are different kinds of sleeping pills. So there are a few classes of sleeping pills, some called benzodiazepines like lorazepam, some are called Z-drugs like Zopiclone, and then there's a bunch of over-the-counter products like the Sleep Easy diphenhydramine products, as well as some others I've listed there. All these medications cause drowsiness to help sleep, which is why people are taking them. But unfortunately, this effect doesn't turn off as soon as we wake up. So if a person gets up at night to go to the washroom, this medication is still in their body and can make them sleepy and affect their balance. These medications can also often last longer in the body of an older adult versus somebody who's younger, just because it takes longer for their body to clear it. But because of this, sometimes the sleepy effects can last well into the next day and cause more of that risk of falls. Other groups of medications that can increase falls risk are antidepressants and antipsychotics. These medications work well for the various mental health symptoms they're prescribed for, but they do unfortunately come with side effects like dizziness and can sometimes make a patient tired or sedated as well. Like the sleeping pills do, this dizzy or sleepy feeling can affect a person's balance and make them more likely to fall. And some medications are better than others for this in the classes, so sometimes that might be why one is prescribed over another. Many of these medications in these classes also have what we call anticholinergic side effects, which really just means they work on certain receptors in your body. And some of those receptors in your brain, and when they are activated, they can cause that just means that those medications can cause confusion or sedation as well. So drugs with anticholinergic side effects are also linked with falls. It's just another way that they cause falls. A big group of medications that can increase falls are those used for blood pressure. I'm not going to read off all of them, but there's, the water pill diuretics, as well as more broadly blood pressure or cardiac medications. As you all know, we need to control blood pressure to reduce cardiac risk, to reduce things like, stroke and heart attacks, and that's important. But lowering the blood pressure can cause dizziness, especially, like I said, from when standing up from sitting or lying down. The good news is that often these adverse effects improve in a few weeks after taking the drug. And so when this is the cause of the falls or dizziness, sometimes we don't have to take away the medication, and patients might actually get better from the dizziness perspective. Pain medications are another group that can cause falls. So opioids have tons of side effects, from dizziness and confusion to constipation. Whether they're taken by themselves, like morphine, or in combination products like Tylenol 3 that has codeine, they can still cause these side effects and are linked to falls. The other group of medications are muscle relaxants, and in products like Robaxacet, these can even be bought without a prescription. So somebody can be taking them without anybody knowing them because they don't even have a prescription, and that can increase the risk of falls. Unfortunately, all of these classes cause sedation and dizziness, like the opioids and the muscle relaxants, so can also contribute to falls. That is a snapshot of some of the medications that are higher risk for causing falls. And now I'll hand things over to Beverly Ann.
Thanks, Sandra. Sorry, excuse me. So now that we've highlighted some great examples of medications that can cause falls, let's discuss an approach to reduce risk from medications. The first question that helps guide our assessment is whether the patient is currently falling or experiencing symptoms that leads to falls. If the patient is currently experiencing symptoms such as dizziness, orthostatic hypotension, volume depletion, excess sedation, or impaired motor skills, then we want to target these symptoms first and can look for medication causes. Then we want to look for the highest risk factors, such as additive effects, medications with the highest rates of falls-related adverse effects, and asking about substance use. The risk factors are helpful to categorize the medications, and the symptoms allow for a more targeted assessment. I'll go through some helpful points for the assessment, but please note that this is not meant to be fully comprehensive, as many questions or considerations are case-specific. As we are all aware, dizziness is a very general symptom and can occur on its own or in combination with any of the other symptoms listed. If we are looking for orthostatic hypotension or hypotension in general, then we of course need to check blood pressure and orthostatic vitals. If the patient is experiencing a positive orthostatic drop, then we could be educating on the non-pharms for orthostatic hypotension, such as rising slowly or using compression stocking, to reduce the risks of falling while awaiting medication changes. For both orthostatic hypotension and for volume depletion by itself, we need to assess fluid intake while we are looking at medication causes, such as diuretics or SGLT2 inhibitors. And to help guide medication changes, consider adjusting the patient's BP targets for frailty and falls risk when appropriate. I won't go further into this because it can be a talk on its own, but there are some situations where we can use our clinical judgment to weigh the risks and benefits of type BP control. And in some cases, the risks of falling will outweigh the impact that a looser target has on cardiovascular risk, but this is very patient-specific. And there are also cases where patients can experience orthostatic hypotension with a very uncontrolled BP as well. So really it becomes a delicate balance. When assessing for whether excess or daytime sedation are contributing to the patient's falls risk, you want to assess the timing of the patient's falls or symptoms, which will help to guide which medications may be likely contributors and whether timing of the meds or activities can be adjusted. One situation where the timing is especially important is if the patient is taking sedating medications at night and the patient is falling when they wake at night or in the early morning. If the patient is falling overnight, it's also helpful to consider why the patient is waking through the night, such as, is there nocturia causing them to be up multiple times, or is pain waking them? Next, we want to reassess whether the medications have had a clear benefit. Many patients are started on medications, such as for insomnia, for example, and feel that there has been no meaningful benefit, but then they are being kept on these medications. And if it isn't clear, then it may be warranted to consider a trial reduction or discontinuation to assess for worsening of symptoms. It is also helpful to proactively use objective measurement scales to help monitor changes in symptoms, such as for pain or insomnia, which can then be used to guide the medication changes. If the patient is experiencing excess sedation or drowsiness, then we also suggest encouraging the patient to limit or avoiding using alcohol and/or cannabis in addition to their sedating medications. Then after we do our systems assessment, we can look for the highest risk factors related to meds. The risks of polypharmacy and additive effects are important considerations whether or not your patient is currently experiencing falls. Additive effects are also known as pharmacodynamic drug interactions. Oh, sorry. I hope you can hear me a little better if I move a little closer. Additive effects are also known as pharmacodynamic drug interactions. And when it comes to falls, we are particularly interested in additive CNS depressant effects, such as from our benzodiazepines, antipsychotics, or opioids, as well as hypotensive effects, which includes our BP medications and diuretics, for example, as well as anticholinergic burden. There are many medications with varying levels of anticholinergic effects, and if you aren't sure whether medications have anticholinergic properties, then it can be helpful to use tools to identify anticholinergic burden, such as the ACB calc, and some may surprise you. It is also important to be sure that we are asking about OTCs, or over-the-counter medication, as many are anticholinergic, such as Gravol or dimenhydrinate. Anticholinergics can be used for many things, including insomnia, nausea, or urinary incontinence. So assessing for potential alternatives really depends on the indication and clinical picture. It is also helpful to group medications in terms of the mechanism of how they can cause falls. And then you can either target the ones that are causing the symptoms that the patient is experiencing or the symptoms that are most concerning based on the clinical scenario. We also want to look for any prescribing cascades that may be present and involve potentially inappropriate medications, which can be very helpful to guide the deprescribing plan, as well as medications that can be easily stopped, which we commonly refer to as low-hanging fruit. It is beneficial to stop low-hanging fruit, whether or not they are huge contributors to falls risk on their own, because as Sandra mentioned, polypharmacy itself increases the risks of falls. And it can also help to build the relationship with the patient around deprescribing if it isn't always so scary or overwhelming for them. One of the biggest takeaways here is that the goal does not always have to be discontinuation. If discontinuation is not feasible, then a reduced dose can still be beneficial for reducing the risks, as often the risks of falls increases with higher doses. We have all experienced situations where the patient is attached to their medication, and they may not be willing to agree to deprescribing, but they may be willing to agree to a reduced dose, and it can be framed as a trial, where the medication can be continued at the lowest effective dose if it's beneficial and appropriate. In most scenarios, there are opportunities to optimize non-pharmacological options, which allow for further reductions in medications. So optimizing our non-pharms can help reduce the risks associated with medications. For sleep, there's very strong evidence for CBT, or cognitive behavioral therapy for insomnia. For pain, there is also some evidence for things such as yoga or meditation, mindfulness, or as simple as alternating hot and cold. Some of this depends on the types and locations of the pain, but it is worth exploring. Another example is for managing blood pressure. A low-salt diet and exercise can help to treat hypertension. This often isn't enough on its own to avoid medications, especially if someone has more cardiac comorbidities, but it can be helpful in reducing the amount of medication required and lower falls risk. There are many more different examples of how non-pharm approaches could be optimized, but I just wanted to highlight a few. And before we get back to our case, we just wanted to share some resources that may be helpful, which are also being shared in the chat. The first one is the Center for Effective Practice, which has some information related to falls prevention and is targeted towards healthcare providers. I also had to plug some deprescribing resources. Reducing these medications can be challenging. Deprescribing.org has some great algorithms and patient-directed resources, such as the benzodiazepines and Z-drugs. And as well, there is Jerry Medress, which is a great resource if there's a complex case that requires additional guidance. We can help to provide some suggestions to clinicians. However, the referrals to Jerry Medress do need to be done by a prescriber, an NP or physician currently caring for the patient. We have also included some patient-directed resources, as these can often be handy while having these conversations with your patient. One is a fact sheet about medications linked to falls. Another is a fact sheet on preventing falls. And then lastly, there's the Too Fit to Fracture handout from osteoporosis, which talks through some exercises that are helpful for preventing falls. So now let's circle back to Grace. So we're going to launch another poll here, and we're going to see which medication would you like to target first? Because as we highlighted, there were a lot of concerning medications on Grace's medication list. But now we want to make a plan for how we're actually going to address her medications. Okay. And we'll give everybody some time to answer this. Okay, I see some great answers come through. We'll give it a few more seconds, maybe. Okay, great. So we have a lot of people going for that Gravol first, and then with 67%. And then next highest is 17% with the Tylenol 3. And then we have a couple with the amitriptyline. And then just a couple of people with the metoprolol and the lisinopril too. Excellent. Okay. So I'm going to share our thought process and approach for addressing these medications. And as I go through this, if you have any questions about the case or questions in general, if you want to, feel free to put them in the chat or the Q&A, and we can go through the case together. But essentially, starting with our approach, we're looking at her symptoms. So of course, she's currently experiencing falls, and she's also currently experiencing dizziness. And now in this case, she did also mention she was experiencing some nausea. And while that's not directly linked to falls, we don't want to forget about it because it is an important new symptom that she's experiencing. And so then if we're looking at our highest risk factor, we have those additive effects. So we have the CNS depressants, so that Tylenol 3, the Gravol, and the amitriptyline that everyone identified as concerning. We also have the additive effects for hypotension with metoprolol and lisinopril, and anticholinergic effects with the combination of amitriptyline and Gravol. And Then, with that symptom of nausea, it actually identifies a potential prescribing cascade because the codeine that the patient has recently started in the Tylenol 3 can commonly cause nausea, and then the patient is taking the Gravol for it. So this helps to identify where we want to start. And I'm going to highlight the plan here. Is there any questions before I highlight the plan?
I don't see any so far, so I think you're good to go forward with the plan.
Okay, perfect. So to optimize, so for our plan, we have optimizing the non-pharm approach. So the first thing that this could be particularly helpful for is the pain in general, because she recently started the Tylenol 3 for knee pain. And then also the nausea, because if we could replace that Gravol with something else, then potentially ginger chews, or there's also non-pharms for nausea, including eating smaller meals. But where we actually wanted to go first with this case, or we'd say, would be to stop Tylenol 3. And now this does require tapering. So likely you can start tapering Tylenol 3 and addressing something else, because the Tylenol 3 is likely causing the dizziness and the nausea. And it was a new onset of new start for knee pain and osteoarthritis. So it would be better to start with alternatives such as regular Tylenol. And of course, there's also further alternatives like topical NSAIDs, etc. And then with that, hopefully the nausea is controlled, and then we could also stop the Gravol. And then we would want to reassess the dizziness, nausea, and falls. And in this case, there was no orthostatic hypotension, so we didn't consider the blood pressure medications. And while I do agree that the amitriptyline is concerning, we can always circle back to reassessing that after we get these immediate changes done. Okay.
I think we're good. There haven't been any questions. I just wanted to highlight that, everyone went to the dimenhydrinate or Gravol. Oh, sorry. I tried to put a cover up on my window. It didn't work. And so everyone went to that, which is a great column. I think one that we all identify as like a major concern for older adults. The difference here was that the Tylenol 3s or the acetaminophen and codeine were being used regularly. And so she was taking it 4 times a day and all of the time. And actually that was likely causing all the other issues, which is one of the reasons in terms of medication approaches, Bev and I felt that we would probably err towards picking that one first. In other circumstances, everyone is absolutely right that Gravol is something we would want to look at and consider deprescribing or helping support in different ways too. So that's all I wanted to add. Thanks, Beth.
Thanks, Sandra. And so today we did share a lot of information and highlighted several medications that can be related to falls, but also included an approach to falls for patients who are at risk for falls. So this includes performing falls assessment regularly for our older adults, which can be as simple as asking a question about whether they have been experiencing falls, or a more in-depth discussion depending on the patient. Then we want to assess for symptoms leading to falls, such as that dizziness, excess sedation, or hypotension. And then we want to include medication reviews when it's appropriate. And with that review, consider additive effects, low-hanging fruit, and prescribing cascades. We want to optimize non-pharms and consider making a deprescribing plan that can involve a goal of discontinuation or using the lowest effective dose whenever possible, all of which help to reduce the patient's risk of medication-related falls. I've also thrown up our references here, and I don't think there was any questions in the chat, but I think we're also running out of time. So
thank you so much, Beverly Ann and Sandra, for an exceptional presentation. Lots of clinical pros, that's for sure. We just wanted to draw your attention to our upcoming practice short for November. You'll notice a difference in time. We have Dr. Gardhouse presenting on November 14th from 8 a.m. to 9 a.m. on spotting and supporting frailty in older adults. We will also have Dr. Ho presenting on deprescribing for the older adults with medical complexity. So stay tuned for more information on Dr. Ho's event. We will send an email out around the details of her presentation to our distribution list. And Jackie also popped in the chat box a resource handout, which includes the resources that Sandra and Beverly Ann mentioned in their presentation today, and also some information on our November practice short. And we can go to the next slide, Beverly Ann. Thank you. And then lastly, we just wanted to draw your attention to regional educational opportunities. So you can always check out our website and register. And again, thank you so much, Beverly Ann and Sandra, for a great presentation. Take care, everyone.